Good afternoon, everyone, and welcome to today's webinar Wednesday. My name is Devin Smith, and I am the Director of Membership and Meetings for Medicaid Health Plans of America. And today we're joined by Sarah Ratner, Government Programs Executive Consultant, and Peter Elizen, Director of Analytics and Data Science from Rebel, for an engaging webinar discussing the critical role data plays in health engagement and addressing social determinants of health. During this webinar, you'll learn how social determinants of health data can help you create actionable engagement strategies to improve health outcomes. You'll learn the importance of data-driven strategies to reach and move more members.
Hey, Devin, this is Peter. I think we lost you for a minute there. Hey, Devin, are you able to hear us? We can hear, okay. All right, tell you what, team, we are going to, it seems like we lost Devin for a minute there, but we'll on with the show, so to speak. My name is Peter Eliason, and I am the Director of Analytics and Data Science with Rebel Health. And so certainly the discussion that we'll be having today is near and dear to my heart, because we'll be talking about data and how to collect it and ultimately how it can be used to improve health outcomes. And I'll pass it on to Sarah next.
Sure. So this is Sarah Ratner. I'm the Executive Consultant for Government Programs here at Rebel. Have 30 years of experience in this area working with underserved population. So today we are going to cover what are social determinants of health. Many of you on the phone already know that and have studied it, but we'll cover that briefly. We'll talk about how social determinants of health can help you create actionable engagement strategies to improve health outcomes. We'll also go through the importance of a data-driven strategy to address this area, and then finally, what are 7 strategies that we use to impact outcomes. So what are social determinants of health? We usually think of this as the conditions that affect individuals at birth and throughout their daily lives. It's the creation of social and physical environments to promote good health for everybody. So there's a lot of facets to social determinants of health, and what we're seeing is that there's more and more being defined or being included within this realm, but typically socioeconomic status, education, employment status, physical environment, and social support networks, ultimately culminating around access to care. So these social factors have been shown to have an enormous impact on health outcomes. There's a high correlation between social determinants and health. So a couple of examples here. The emergency room has been linked to homelessness. We commonly hear of ER boarding that can happen. Diabetes-related hospital admissions have been attributable to food insecurity, as well as social isolation has been related to stroke and heart attacks. Interestingly, a college degree is associated with living longer, and then education, racial segregation, social support, and poverty, that actually is attributable to mortality and accounts for over a third of total deaths, sadly. So some common barriers include economic stability, the neighborhood you live in, The lack of access, whether it's food, access to care, access to daycare, access to family, education, and language. Language can be a huge barrier and is obviously included as a determinant. And then your health literacy. If you aren't able to understand why you need, for example, a flu shot, that's a very large barrier to actually getting somebody to take that action. So recently, we looked at, or I saw a Milliman Conference presentation that reported the risk of having a health condition is highest among those with the lowest income. And those with concerns about life necessities are 2 to 3 times more likely to report fair or poor health than those with little or no concern. So this area is being studied and is, academically being covered in a much broader sense, in a much more intense sense, which is great. So here at Revel, we're working with health plans to address and screen for social determinants. And this is a process that we use. The first is we need to identify patients who have or are likely to have multiple health and social needs. The second is screening for those patients for the determinants, understanding what they actually are, and then appropriate organizations with resources and the knowledge to address their specific needs. So the knowledge and the connection to those organizations is critical. And actually, one state Medicaid director recently said, and I'll quote her, "I don't know that piecemealing some of this is going to help. If a hospital says they're going to do screening for food insecurity and then make a referral for food insecurity, that's a good thing. That's a great step in the right direction, but it doesn't get into a holistic view of a person's needs." So there's been a trend to address this and pick it apart, but now really the state and the government are driving towards a 360 approach. We also look at connecting patients with these community organizations to help address these health-related needs. That connection, the specific connection is critical. Rather than deploying just a wholesale strategy and saying, we'll try this, we have to be very intentional about what will match the individual's needs on a micro level. It's critical to follow up to ensure the patients were actually connected and facilitated the access and the completion of the intervention strategy or the activity. And then so that everybody can understand the efficacy, tracking the outcomes of patients receiving these community-based services is an imperative that's needed. So this helps us really understand what's working for the members and modify or augment very quickly to meet their needs.
So as Sarah alluded to, this is a process. And where should the process begin? Well, it should begin with data. And that brings us to our first strategy, where we encourage individuals looking to build out this practice to use all the data. And so data isn't available necessarily when the organizations start their social determinants of health practices. It needs to be collected. And so there's many different ways that we can collect this type of data. We can collect it from screenings and health assessment. This type of data can be obtained, member information beyond just the enrollment. We can also incent providers to collect social and health data at the initial visit. And there's also opportunities to collect data through credit agencies and certainly at the census level as well. Census data provides information about education levels within the area, employment status, frequency of homelessness, different crime rates or law enforcement records. And we actually know that an individual's zip code is a stronger predictor of his or her overall health, more so than many other factors, including race and genetics. And it's also important to note that during a payer or provider's interaction or lifetime with the member, it's important to be collecting feedback at all the relevant engagement points. Once this data has been collected, it's not sufficient just to be storing data in a database somewhere and calling it good. We need to be able to translate this data into action. And so one way that we think about it is there's this notion of zip code health. And so this is in an entire healthcare category devoted to understanding the result or the importance of how variables at the zip code level can actually translate to outcomes at an individual level. We want to be able to target members at a single point in time with the highest level of relevancy. And certainly we can do that through the data that we collect. And especially as we'll talk about further on in our conversation, how this type of data can be merged with claims data to target members for programs that help eliminate the social barrier and determine who is most vulnerable. Certainly, this type of information can also be driven to understand which channel in which time of day would be best to be targeting these members with the relevant messages and programs. So once we have this data, it's important for us to be able to prioritize who we should be focusing on. And so one way that we like to step into this is considering just two axes, right, where we've identified individuals as either working or non-working, those individuals who are below poverty or above poverty. And what we've done here is just overlaid kind of a very simple segmentation of quadrants where number one is probably the most important area to start. So these are individuals that are below poverty and they're non-working. And so from what we've seen is these are the types of individuals that probably have the highest degree of barriers that need to be overcome or addressed. And so this is certainly the highest area of focus that we recommend. And then as we move along, number two would be below poverty but working, individuals on Medicaid but that are able to work. And then three would be in the next step. And then finally four, there are potentially individuals in this quadrant number four that would benefit from different social determinants of health programs, but they probably aren't an immediate focus for an organization that's early on their journey of developing these types of programs. And so let's take this a step further. And so we like to think about this also, these quadrants as being supported by all the different types of data and elements that could be relevant to an individual. And so let's look at an example. This is Renee. And so here we know that Renee is below the poverty line, but she is working. And for things that are important to her, things that are, sorry if I'm cutting out, folks. I'll try to go a little bit slower here. But things that are relevant to her is that she needs more community support. Or we've identified that she lives in an area where there is high crime or where she does not feel safe. And we also know that she needs access to transportation, right? This is all information that we can collect, like I said before, in an assessment that we are able to conduct with her, or it's information that we can collect from the census data, or it's information that we can buy from a third-party vendor. But ultimately, all of this is combining to tell a story about Renee individually and the profile that describes her. As another example, here's Roger. And here, Roger, even though he is not eligible for Medicaid, because you can see he is above the poverty line, but the point is that all individuals are affected to some degree by these social barriers. And so we see for him, education is something that is relevant to him. Maybe he is struggling with employment because you can see that he is plotted on the non-working side of the spectrum. And family, maybe he doesn't necessarily have relatives or friends nearby that are able to assist him or that he can lean on for moral support when he needs to. So these are all types of things that are important for a plan or a provider to understand as they're trying to make recommendations for Roger as an individual. And so let me tell you a story, kind of bringing this all together. This is a story about Larry and Bill. And so Larry and Bill, on paper, both look very similar. And so this is the type of information that a payer or a provider would have. We would know the age of both of these individuals. We would know the zip code, and so we can probably plot density to understand if there is an urban or a rural designation. We would understand enrollment date, and we would also have an idea based on claims of some conditions that both of these individuals have. And so at the onset, they both look very similar. However, once we begin to layer in more of these social factors, it begins to paint a different picture about both of these individuals. So, for example, let's look at Larry. So here we see that Larry does not necessarily have any participating primary care physicians within 40 miles of where he lives. We also see that Larry's income is below $25,000, so certainly kind of in that lower income side of the spectrum. He has a high school education. He lives alone, and he lives in a neighborhood where there is high crime. On the other hand, when we look at Bill, we find that there actually are doctors and hospitals and clinics within 10 miles of where he lives, so much more accessible. He has a much higher income, above $150,000. He has a 4-year degree. He lives with a spouse and relatives nearby, and lives in a safe neighborhood. This is all data that we can find out about these individuals, and then using that data, it allows us to plot both of them on a risk spectrum. And so what you can see here is we've identified Larry as having a much more significant degree of risk beyond what we can see from the claims information. And so there's certainly other types of programs that we would consider for Larry as opposed to Bill. Bill has a much lower risk than Larry based on all the other social data that we know about him. And so we may not necessarily want to encourage all of the same programs as we do for Larry.
So, just to chime in there, one of the trends that I'm seeing and a much stronger focus of business and actually early stage companies is social isolation. So this is one of the biggest variables that exists right now, and there are a ton of health outcomes that are tied to this. And the focus on this is almost as a subset of social determinant screening measured through loneliness indices. One of the facts that I find staggering is studies show loneliness can have the exact same impact on health as smoking cigarettes, which really goes to why there is such a need in the space right now to deal with these issues.
Yep, thanks, Sarah. Yep, good to have all of that information to be able to tell the story. And so ultimately, putting this all together, we just want to reiterate the fact that the bigger framework tells the full picture of Larry and Bill, both the claims information and the social information, and that allows us to develop a strategy that is more appropriate for both of these individuals and the programs that would be relevant to them.
So one example that I like to focus on because it's very realistic. There's a woman who takes the bus to work every day. She's got 3 kids, so she has to drop them off at daycare, works her heart out, and then has to take the bus to pick them up. And buses can be late. In our city, they can be notoriously late at times, especially with weather. So she gets there 10 minutes late, and she has 3 kids. And oftentimes, daycare actually charges you for every minute late. So the bus running late actually negates her entire salary for that day. So she's wiped out. And if you think about this around health as well, if I'm making the decision of do I go to the doctor or not, all of those different barriers to actually getting there, if the doctor doesn't run on time and then you're late to pick up your kids, there's a lot of factors that we all experience every day And often we take them for granted, but they are real barriers that we have to figure out how to solve for in order to get these people the right access to care. So connecting all the dots. We all know that data is very useful to health plans, providers, and the states, and it really does enable a closed-loop process if we use it correctly. So we use this to provide information on enrollee needs and understand the extent of intervention effectiveness to support the understanding of the program needs. So how is the program working? Does it need to be modified? This information can also help states understand social and economic issues and the magnitude. So there's this effort to really coordinate sharing of data between plans and states so that there's a holistic or a more holistic approach. We need to determine if the interventions are actually affecting the outcomes. So interventions in housing, food, transportation, what impact do they have on health outcomes? Because we don't want to keep putting money into the space if we're really not getting the results and the impact on the member. We highlight information on the social service organizations that help the members most. So like segmenting individuals on a micro level, we need to segment those social service organizations at the same level so we can precisely match, based on an individual's need, match them with an organization that will actually satisfy that need. And then one of the areas that is becoming a greater focus in healthcare is PROMS data, so patient-reported outcomes. And to the extent that we can get access to functional outcomes rather than just claims data, that is very rich information. So we can say, for example, somebody was able to, with access to better transportation or a Lyft service like we see being funded more often, they were able to get to their kids' daycare on time. Well, we don't see that through claims data. We see it through essentially functional outcome data that is collected to understand, whether or not this is actually working. And we don't want the claims data because it could mean possibly that it's not. So at Revel, the clustering and channel optimization allows us to figure out the best way to connect the individuals and providing this information to the state and the health plans and continuing to augment it in real time so that if something doesn't work, you move quickly to something that actually does. The next strategy is don't be afraid to innovate. This can be a scary space to get into and somewhat daunting and seem insurmountable. With the increased focus, we're seeing many different state emerging trends and best practices. So plans and providers are moving much beyond screenings to more systemic efforts to connect enrollees to social support. So a much stronger integration to primary care and how that interacts with the state and the health plan. Plans are expanding their social determinant population or how they define this population. Most recently, I'm seeing a much greater focus on those that are incarcerated and when they're coming out of jail or prison, how they're transitioning back into daily life and having plans apply resources so that they're successful in integrating back into daily living and also getting the healthcare needs met. States are using a number of regulatory levers to help build these networks. Many of you know about the 1115 waivers, and we're seeing a ton of innovation around that. Most commonly are the work requirements, but we're seeing it in the social determinant space as well. State incentives are a big area for driving innovation in this space. And then there's more and more requirements around data operability, or interoperability, I should say. An example is Georgia has a program, it's called the Medicaid Promoting Interoperability Program, or formerly EHR Incentive Program, that really helps drive to answering the question of how do we share data to understand the member at a much more micro level. states and health plans are experiencing a greater need for creativity around how to make these resources more affordable. So not just the typical approach of giving somebody a bus pass, but how do you incorporate Lyft in an affordable way? What are different ways of accessing housing, or, like I mentioned before, daycare? Similar to the regulatory levers, states are also using financial incentives to drive innovation in the space. A lot of the pay for performance, performance improvement programs, quality improvement, even withholds, they're starting to be more focused around this space to help encourage plans and providers to take steps to help with these interventions. And state plans and providers are continuing to use this data more and more to create the closed loop process and expand data availability and access. We're seeing this at a much faster pace at the federal level with the Blue Button Initiative, but states are starting to see what's going on at that level, understand the importance of sharing the data and getting into the space of figuring out how do they solve for this. The next strategy is leverage the state, work with the state. These state Medicaid directors are coming up with some really cool, innovative ways to deal with these issues. And the federal and state requirements, we can leverage them to actually help solve this problem. A couple of areas that I'll focus on is more traditional services are being permitted to be covered, and these are even included on the MLR side of the ledger, so defined as incurred claims for MLR purposes. One of the areas that they're leveraging this regulation, or care organizations are leveraging this regulation, is through the in lieu of service regulatory requirement, or I should say permission, that was included in the managed care, Medicaid managed care regulations in 2016. These are alternative services or settings that the state determines to be medically appropriate and cost-effective, a cost-effective substitute for covered services or a setting under the state plan. So an example of this would be prenatal visits, allowing those visits to occur in somebody's home rather than forcing them to go to a hospital. That could seem scary and maybe not culturally conducive. There's a lot of reasons we know why pregnant women do not go to the hospital, but really bringing health care to the person rather than forcing a person to dovetail into the healthcare system. Also, the in lieu of services regulatory requirement allows for those services to be counted towards the capitation rate setting. The other area are now health plans can provide value-added services, and these are really extras that aren't related to the contracted services. So things like nutrition classes, peer support services for mental health, but these do not count in the capitation rate setting. We also see very recently the federal government released the final call letter, and as many of us know, they completely expanded and blew out the ability to provide supplemental benefits, so for the chronically ill. And these supplemental benefits can fund a lot of the resources that help to close the gap on the determinants. And we're seeing health plans innovate around this dramatically. There's just a ton of efforts, and it's really interesting to see the approaches that are being taken and the innovation around it. There is a continued effort for CMS and the state through guidance to give plans the ability to fund these different social determinant of health initiatives, so housing, education, and the like. As I mentioned before, states are using the 1115 waivers, and some states are even requiring participation in social service initiatives, so using more of a stick. a couple other areas that states are covering. 35 states require managed care organizations to screen members' social needs and permit them to engage in coordination with providers of non-medical social determinant-related services. 24 states require partnerships to connect individuals to social service agencies as part of their state contract with the health plan. 13 states require quality improvement activities to focus on a member's social determinant of health, allowing, actually giving support only for what is evidence-based and to provide a more focused framework for future social determinant of health approaches. Two states that we found that we can identify have withholds or incentives linked to this, and then 10 have value-based payment initiatives. One of the things that our plans have found useful is we put out a document that has all of these different requirements and initiatives in this, and you can access that by going to Rebel Health, and it's really a compendium of what states are doing, whether it's requirements or ways to add incentives to dive deeper into the space. As I've mentioned, plans are using a number of different strategies, from linking members to social support services to interdisciplinary community teams. But almost uniformly, there's some type of incentive around this tied to healthy behaviors, which is an interesting way of encouraging members to access these types of services. There's a couple of interesting approaches that I've found with health plans most recently. A survey from Change Healthcare found that 80% of payers believe that addressing this area is a critical way to improve their population. Health Partners also has a program that deals with food as medicine to chronically ill Medicare and Medicaid members. And this is home-delivered meals that are specifically tailored to their health condition and dietary counseling. So if somebody's diabetic, they're not going to send out a box of brownies to them. They're going to actually go through and figure out what types of food will help improve their health. And very pleasantly surprising, this program reduced hospital admissions by 28%, emergency visits by 7%, provider visits by 16%, specialty visits by 7%, and it obviously showed a decrease in their A1C levels. Also, in another example, CareSource, which is a plan out of Ohio, provided its members with no-cost services and support for professional development and employment. And these are totally non-healthcare related initiatives, but as we've spoken about, they really go towards helping to solve for healthcare issues. And the data from that showed that of the 392 participants, there were measurable differences in healthcare utilization 6 months before and 6 months after participation in the program. Emergency room visits decreased by 15.5%. And interestingly enough, pharmacy claims actually increased by 37%. But the whole notion is that this is actually a good thing because people are adhering to their drugs, which creates an indicator for better disease management that may ultimately lower somebody's healthcare costs. So how are plans trying to understand their members? First, more and more plans and providers are deploying health assessments to understand the population prior to receiving encounter data or experiencing costly claims. This is becoming commonplace, and it's very critical for plans to start doing this. And I can't stress enough the need to get it before the encounter data. At that point, we're losing the fight in trying to help these participants. Also, hospitals and health systems can capture this data now through ICD-10 in categories Z55 to Z65. And these groups, as those of you who are familiar with it, cover a wide range of areas, common social, economic, environmental, and interpersonal issues. So we've covered a lot today, but for us it's helpful to boil this down into 7 strategies for how do we address this very large area.
Yep. So just kind of as a reminder, it begins with data and the need to collect the data and take action as a result of it. I forgot to mention earlier too that there's actually requirements, for example, in New Hampshire, Virginia, and Washington, where there are specific definitions that need to be addressed in screenings and assessments regarding some of these social aspects. North Carolina has also established a standard screening tool for food, housing, transportation, and interpersonal violence that will be used by all MCOs. Strategy number 2, if you recall, this is prioritizing the population. So trying to understand and create segments around where to focus first, which individuals are in most need of these particular programs. Strategy number 3 then is what available programs are we going to develop, and understanding how to designate particular profiles for those particular programs. And then ultimately strategy 4 is being able to combine all of the data we have with the claims data to create a more holistic vision around who an individual is, and then mapping that individual to the engagement and resource.
We want to make sure that all the dots are connected. So understanding that there needs to be a single point of connection for the member and to drive them to one place that creates a cohesive solution. So we know that sending a member to multiple places to try and access services, so linking them to housing resources, and then linking them to food resources, and then linking them to daycare, that is overwhelming. So there is a need right now to centralize those and streamline it so that the members get access to these services very quickly and they're not overwhelmed to the point where they say, forget it, I'm just not going to do it. As I've said in the past and in the previous slides, don't be afraid to innovate. People are trying many new things, and things that I thought wouldn't work or maybe a silly idea, I'm seeing take off dramatically. And I can send you guys a couple of examples by email if you'd like. And then leverage state financing. We're all in this together and trying to figure out ways to improve the population. So working with state, giving them ideas of what's working, and helping them make this easier to solve for seems to be a very critical component in trying to solve for this problem. So thank you for attending today, and we'd like to open it up for Q&A.
Absolutely. Thank you so much, Peter and Sarah. We do have a few questions on board. First, we have one from Brian. How do you address health provider burnout from too much time spent inputting data on electronic health records rather than face-to-face time with patients?
I'm sorry, can you repeat that? You were just breaking up a little bit.
Absolutely. How do you address health provider burnout from too much time spent inputting data on electronic health records rather than face-to-face time with patients?
Yes, go ahead.
Oh, I was going to say, I mean, there's certainly different opportunities to collect data about individuals. There's automated processes that can be used to collect information, or assessments that can be handled prior to the actual visit. Nurses and doctors know just as well as any of us that entering data and collecting information from people can be monotonous, and so there certainly are opportunities to use machines in order to expedite that process. But I think, certainly once that data is there, it allows the individuals at the provider level to be thinking about how do we connect the individual to the right programs, and how do we use this data to provide a better experience for that individual.
So one of the things I'm also seeing is electronic health record companies are becoming more sensitive and attuned to the need around this, and so they're incorporating faster processes in their programs to help take a provider through kind of a social determinant of health assessment, so that it's much more streamlined rather than having to focus their visit on answering a series of questions. That way they can capture this in the record, but their discussion can really focus on the core problems that the member is dealing with.
Great. Our next question comes from Adam. What are some specific examples of payers innovating on SDOH that you have seen?
Did you say what are the specific areas that people are innovating?
Yes, examples of payers innovating on SDOH.
Yeah, so one of the coolest things I think is going on right now is a company that is providing grandparents on demand. They are matching college students with Medicare eligible individuals and giving these folks the opportunity to have a companion. So they may have somebody in their house for a couple hours a day to take them to the grocery store, look in their refrigerator, kind of do a micro health assessment that they can help share with the health plan to give them a better sense for how these people are doing, or even just things as simple as playing bridge with them. As I spoke about, the social isolation is enormous, and companies like that they're very simple problems, but they're tackling it in ways that is creatively using the data and helping to provide the health plan with that, as well as getting the data from the health plan, so that there's a real understanding of how this member is doing outside of their claims data.
Okay. And then from April, we have, can you repeat the ICD-10 code for PCP to bill for social risk?
Sure. It's category Z55 to Z65.
And then from Paula, yes. Could you please send out the website where state requirements are housed? Can you please let people know that, the website where state requirements are housed?
Absolutely. It is on a previous slide where you go to rebel-health.com/resources. We can also send it out to this group as well. We're happy to do that.
Perfect. Yeah, there were questions if you were all going to be sending out the slide deck as well.
What we're going to be doing after this is we're going to put out a white paper around some of the detail in this, so we can give this group a bit more detail and go in greater depth around some of these strategies. So we feel like doing that instead of a PowerPoint would be helpful.
Great. And then from Adam, how do you bring all of the disparate data together into a single place to create usable insights on a member to close SDOH gaps?
Yeah. So certainly that's not there's not a one size fits all for that type of solution, but certainly being able to have the different sources available and being able to leverage all that data and create specific joins to be able to combine that data is important. And so certainly We talked about different sources of data that can be gathered. And so there's claims data that's coming in from different claims systems. There's census data that can be gathered directly from the census website. And there's assessment data where we can actually be asking the member or patient specific questions, and that comes from a particular vendor, such as Revel. It's one of the services that we provide. That data can all be combined into a database within the payer provider's ecosystem, and then there's work on probably from an internal analytics team to be able to determine and build profiles around who these individuals are, building segments around what information can be used to identify what programs might be relevant for this potential population. And all these types of things can be joined to each other, and we can certainly go into more detail on that during the white paper, but certainly this is the information that Revel uses all the time, that we are familiar with, and so we're certainly happy to kind of dig more into that if there are specific questions around what would this take.
Okay, perfect. And then we've known for a while that health outcomes are more than just seeing a doctor. Why is this such a focus now?
Well, I think for a number of reasons. One, there's just more data available. Healthcare, as we know, it's been very siloed and condition focused. And with all the different types of data that we now have, there's an effort to start actually utilizing it. So we've hit a tipping point. And I think that is just causing just a greater awareness of the need to use this data, the need to actually collect it, and figure out ways to deploy strategies that can help with health outcomes.
Great, thank you. How does interoperability and what the government is doing with the blue button impact the understanding of the member?
So what CMS has done is they've established the blue button, and we went into this in a podcast we did recently. So you can go to the Revel website and access the podcast that describes this in more detail. But generally, they've established the blue button where a Medicare beneficiary can go and click on the button, and it gives them access to all of their data. And what we're seeing happen is people are using this somewhat antiquated HIPAA right of access. So individuals have a right to access all of their health information. The member then says, I want access. They go through the blue button and get that access. And then they assign the access to different organizations so they can actually use that data. And the data structure is one that is consistent, that can be used across multiple platforms. And so this right of access is allowing additional organizations direct access to people's claims data and then to appropriately use it to help them or help benefit the beneficiary.
Awesome. And then from Melissa, we have, can you elaborate on the 1115 waiver? How does it impact health plans?
Sure. So states can apply for different ways to innovate in Medicaid managed care. Actually, the Medicaid managed care came through an 1115 waiver process initially. And so what's happening is states are saying, you know what, we need to innovate. We need to do different things. We want to try new programs. So we're going to file a waiver that gives us permission to deviate a bit from certain requirements and explore new ways for solving this problem. And then what states are doing with it is saying to the health plans, we need you to deploy this, or we need you to adopt an approach that supports this waiver. We're seeing it with the work requirements. Health plans don't want to lose these members because they become ineligible through not submitting their work requirements. So because there's an 1115 waiver that exists where plans can impose these work requirements, or states can impose these work requirements, plans are taking the initiative to then say, okay, I've got to keep this person, and let's figure out a way to do it. These waivers and innovation around this is also being incorporated into state contracts. So there's a number of states that publish these contracts, and it's typically the sample contract, but the requirements around the waivers are included there as well.
Sarah, you cut out. I'm not sure if everyone got that. Could you repeat? Okay, she heard you. You were cutting out. I wasn't making sure you were heard. She said she heard you.
Okay.
And then one more question. What concerns are there about data privacy?
Yeah, certainly, this is all information about members and patients, and there's certainly claims data is specific to the individual. This is all considered PII and PHI when there's information about a specific individual. So certainly systems that are going to be capturing this information need to be HIPAA compliant. That said, a lot of this data that we've talked about, the census data, for example, is not HIPAA compliant. This is actually publicly available data that any of us can go and download. And so, that is certainly that's certainly information that can be used to create hypotheses and profiles about people, but it's not specific to an individual. It's more at an aggregated level, either at a zip code or a census tract or a block group. And I'm not going to dig into what those necessarily mean, but it's more aggregate information about where kind of trends around where an individual lives that can be used to make business decisions that are relevant for that individual.
Also, there's just an enormous sensitivity, and more so with some of this population, around who's getting their data and concerns about it. So a couple of things. One is figuring out a way to communicate to the member very simply how you're going to use the data, and embedding it in a notice of privacy practice or terms of service is typically not the most effective way to do that. And so deploying strategies where you tell them how you're going to use it and let them know that it's for their benefit. Also, as you look at different health action programs like Revel, it's critical to modify your strategy to these sensitivities. So if you know somebody does not like to provide electronic data, don't ask them this information electronically. It's probably better to pick up the phone and engage them that way. So being able to embed that sensitivity and that way people want to access their data is absolutely necessary in these health action programs.
Amazing. Again, I want to thank Revel Health for being with us today. If you all want to quickly just go back to your slide with your contact information so people can get that. But I want to thank everyone for your time today. And again, Revel Health is on that white paper and additional information resources for you all as a follow-up. And we hope to see you again on one of our next webinar Wednesdays. And there's their contact information if you wanted to have it. And again, they'll have your information to follow with you with those resources. Thank you again, everyone, and have a great day. Bye-bye.